want to welcome you to another edition of our webinar on the science, policy, and politics of COVID-19. I'm currently a faculty member at the Perelman School of Medicine at the University of Pennsylvania, also a proud alumnus of Albion College. This webinar series is being sponsored by the Lisa and James Institute of Medicine at Albion College. Before we get started, I just want to review the format for the next hour. After our featured speaker, Troyen Brennan, makes some introductory comments, I will introduce the students from Albion who will be holding a discussion Q&A with Troy. I'd also like to invite from the audience any questions, and I'll try to get them in and share them with Troy. So I'd like to now introduce our featured speaker, Troyen Brennan. Troy is currently the Executive Vice President and Chief Medical Officer at CVS Health. Troy got his undergraduate degree at SMU and on a Rhodes Scholarship received a master's at Oxford. He then went to Yale and received his M.D., M.P.H, and J.D., and then went to Boston, where he's been ever since. I met him in the first day of his internship or residency at Mass General Hospital, where we were residents together, and got to know Troy in a very in a bonding experience as it was back then. After completing his training, Troy stayed in Boston and became a professor at Harvard in medicine, law, and public health. Then he moved to Aetna, where he was Chief Medical Officer, and then to CVS. So it's a pleasure to have Troy here, and look forward to his comments and question and answer later. Troy.
Thanks, Jim. So I work at CVS, and I should give you a little bit of explanation about what we do. It's basically sort of three major businesses. One is the insurance company. It's called Aetna, a health insurance company. And one is a pharmacy benefit management company. It's called Caremark. And then the one that many of you would recognize would be the CVS retail pharmacies. We have about 10,000 of those. So we're now either the fourth or fifth largest company in the country from the point of view of revenues. And we have about 360,000 employees and get involved in all kinds of aspects of healthcare. With regard to COVID, you know, it's clearly something that's central to what we do. The insurance company is paying benefits associated with patients who get sick with SARS-CoV-2 or who need testing, and eventually who will need the vaccine. The pharmacy benefit management company is very for the vaccine. And then mostly what I'll talk about is the work that we've been doing at the retail pharmacies. In addition to the retail pharmacies, we operate about 1,500 retail clinics, and we also are involved in trying to get our pharmacists more involved in healthcare. We're the largest flu vaccinator in the country. We'll give about 22 million flu vaccinations, we estimate, this year. And we want the pharmacists to be more involved in the kinds of things that they can do in healthcare. So with the, at the beginning of the pandemic, we decided to jump in as quickly as possible into both testing and then eventually into vaccine distribution. And I'd say just a couple of words about the testing and then a few about the vaccine, and then kind of open it up. On the testing front, I think as many of you know, there are a variety of different ways to test for the virus. The probably best approach and the one that's most prevalent today is a polymerase chain reaction testing, where you're actually looking for the DNA associated with the virus itself. And that tends to be something that's done in a big lab. It's a send out, which means that you send it out to the lab and the lab gets it back to you. Then there's rapid tests, that some of which are molecular, so they're actually looking for DNA or RNA from the virus, and so many of which are antigen-based, looking for antigens associated with the virus. The good thing about many of the rapid tests is that they're done on a point-of-care basis under what we call CLIA wave. That's the FDA's regulations associated with doing these kinds of tests. We're used to doing those because in our ambulatory clinics every winter we do just tons of flu tests and tests for other things that are on a CLIA waived basis. And so we have the machines that are available to do that. Usually you get the result back in 15 minutes. The problem with the tests, the antigen tests, is that they're not as accurate as the tests that are done on the PCR machines. And so you're constantly sort of looking to see how well those tests compare to the tests that are done on a PCR basis, and trying to calculate the sensitivity, which is related to the false negative rate of the test, and the specificity, which is related to the false positives associated with the test. The antigen tests are now getting up to where they can, in symptomatic individuals, over a reasonable period of time, some 0 to 4 days, some 0 to 10 days, diagnose the disease with sensitivity and specificity that is in the 97 to 98 percentile. And I think that we'll continue to see sort of enhancements overall in the technology associated with the antigen tests. The good thing about an antigen test is it gives you an answer sort of right while you were there. So we've gotten involved in both halves of that, and I just give you a sense, gives you a sense about sort of how an industry like ours is responding. We offer now in 4,000 locations, 4,000 of our 10,000 locations, what we call swab and send. So basically you can get online at CVS, and this is not an advertisement for CVS, I'm just giving you a sense about sort of how we do things. We have digital characteristics available to find out whether or not you qualify for the test, whether you have symptoms or have been exposed to someone. Then we give you an appointment. You drive up at the time of your appointment. These 4,000 places all have drive-up lanes. We do this in the drive-up lanes, and what we do is basically get your information, put the test in the drive-up lane, send it out to your car, instruct you about how to test yourself with an anterior nares application, and in the container, and give it back to us, and then we ship it off to a major lab that then does a PCR test. And at one point, when there was a lot of demand in late July and early August, you know, that could take 6 to 8 days. Now it's down to sort of 2 to 3 days, but it's a good way to get people information on whether or not they are infected over a relatively short period of time. We're also doing point-of-care testing, and we're building specific annexes to our retail clinics, and they'll have their own door and have a testing facility in the small room that'll obviously be heated or cooled depending on sort of where you are in the United States. And at those places, we'll do point-of-care testing, and we'll do point-of-care testing both for flu and for SARS-CoV-2. And the idea there is that as we approach a flu season, we want to have an answer for people who have symptoms. Flu tends to be upper respiratory, COVID tends to be lower respiratory, but there's so much overlap between the symptoms associated with the two syndromes that there's really no way to differentiate. And it's going to be difficult, especially if we get into a situation, which I think we will get into, where we have rising levels again of infection for people to get into a doctor's office when they're symptomatic. So this will allow us to have people come in, get scheduled, get their point-of-care test, go back and wait in their car. If they're negative, they come in for further evaluation of their flu symptoms. If they're positive, then they go home and finish their visit in a telemedicine format, or else be in touch with their physician. So the idea is trying to sort of think through and anticipate sort of what we're going to be seeing sort of 3 to 4 to 5 months hence, and then doing logistic planning for that over the course of the intervening weeks. So it's challenging, but it's proven to be very gratifying for us and our staff. And you know, we're now doing about 8%, maybe 9% of all the COVID testing that's done in the United States. We're by far the biggest provider of testing. And we think we've got a real solution coming up for the flu season. With regard to the pandemic itself, I mean, it's been fairly predictable. What we saw in the initial sort of rise in the number of cases was just simply an unprepared country. And then that part of the country responded and rates dropped, but there were other large parts of the country that were unprepared and didn't get the lesson from the first time around, and then as a result, we saw the infection pick back up again. I'm persuaded by a set of papers I read back in early February that there was going to be this sort of federal geographic response. I think now almost everybody's sort of on the same page, but what we're not ready for is the fact that these viruses do tend to spread much better in a warm, dry environment and indoors. And so as we go back indoors for much of our sort of social interaction, we're going to be dealing with this virus in a substantial fashion coming up. And I think, you know, some places are going to react more quickly and some places are going to react more slowly. Here in Massachusetts, we had 700 cases reported a day. 6 weeks ago, we were running about 200 cases per day. So we're going to start to get to the point where we have to sort of ratchet down again. And I think we'll continue to see this sort of ratcheting process over the course of the months until the vaccines are ready. With regard to the vaccines, I'll say about 4 minutes worth on that. Jim knows a lot more about the biology than I do, but the leading candidates today, the 4 leading candidates that are really in trial, are those that were radically new technology, either using messenger RNA or genetic material that's implanted in an adenovirus and then vaccinated. None of these vaccines have ever been used to a large extent or certainly produced the numbers that we're talking about. But I would say, at least from what I read, and I'm not obviously a virology scholar, but from what I read, they're getting good immune reactions from people who are getting the viruses. And I think that they're basically sort of running their clinical trials in the way that they should be running them. And they'll be doing specific checks when they hit certain numbers of people who become infected in the trial. And then they'll find out whether or not the people who are infected have gotten the vaccine or not. And they have certain stopping points that are based on a statistical analysis of the power they need to demonstrate certain levels of efficacy. And I think that the pharmaceutical companies will proceed sort of according to the book in terms of deriving whether or not the information they'll give us what we need to understand about how efficacious these viruses, these vaccines are. We're more interested in the other side of it, which is going to be the distribution, and increasing the government looks like it's going to be relying on pharmacies like ours, large retail pharmacy chains, to do a lot of this distribution. We've had contact with the government, you know, for weeks now on these issues, and you know, it's becoming clearer and clearer exactly sort of how they're seeing the distribution, which is an appropriate response. I think their first focus is going to be on the first responders, healthcare workers and other first, as well as people who are in skilled nursing facilities and long-term care facilities. And with regard to that, they're trying to sort of identify exactly how they're going to get the vaccine out to those individuals. As you know, some of the, or might know, some of the messenger RNA-based vaccines require extreme cold temperatures in order to remain stable. So there's a lot of logistics associated with it. But I feel pretty good about that part of it, simply because we're good. The private system is pretty good at distributing medications and viruses. So the wholesalers who would do the distribution and ourselves are used to sort of working with one another. And for instance, I firmly believe that we as a company can deliver 20 million vaccines a month. And if you think about just us, we get to 150 million by the middle of next year. If there's that many people who want, and there's that much supply available. Most of these vaccines are going to require the complication associated with giving an initial and then a booster vaccination. But again, relatively sort of straightforward in terms of how that's done. And any of you who ever have had medications at CVS know that we're very good at hectoring you to come back in and get your follow-up medications, or in this case, the follow-up vaccine. So you have to be nothing but sort of excited. I know it's hard to get excited in the United States sometimes these days, but you have to be excited by what breathtaking pace the science is moving here. And even if some of these vaccines turn out not to be too efficacious, I think others are going to be, and that we're going to have a reasonable situation in this country, I'm thinking by midsummer, end of the summer, in terms of enough people having been vaccinated, enough people unfortunately having been infected, that there's going to be reasonable decrease in terms of the transmission of the virus, simply due to the principles associated with herd immunity. So that's kind of who I work for in the role that we're playing, and a little bit about the way in which you sort of see the biology of both the laboratory tests and the vaccines kind of playing into a larger distribution role. But let me turn it over to the students and see what kind of questions they have, and then perhaps we can open it up to the audience, I think is what Jim wanted us to do.
Great. Well, thank you, Troy. Let's start. Just want to introduce the students. We'll start with Michaela.
Hi, I'm Michaela. I'm a senior from Shelby Township, Michigan. I'm a biology major with a Spanish minor, and I'm a member of the Wilson Institute.
Great. Morgan?
Hi, I'm Morgan. I'm also a senior. I'm from Chicago, Illinois. I'm a biochem major, and I'm a part of the Wilson Institute as well.
Becca?
Hi, I'm Becca. I'm a senior from Bellevue, Ohio. I'm a biology major and also part of Wilson.
Paula?
Hello, my name is Hala. I'm a senior from Farmington Hills. I'm a kinesiology major with a marketing management minor and a concentration in public policy. And I am a member of Ford Institute, Prentice Brown Honors Institute, and Wilson Institute.
Great. Well, welcome the students, and I'm going to pass it over to you. I think Morgan's going to get us started.
Yeah. So my question is, how are companies such as CVS able to provide an increase or at least maintain testing rates and availability?
Well, with regard to sort of availability, especially with the lion's share of the testing we're doing today is related to our relationships with large labs. And so we've been contracting, our contract with 4 labs, will probably go up to 6. For use of their PCR facilities, and they have grown their capabilities radically, and I think they continue to grow them. So, and as a result of that, we've been able to sort of open up more sites. So right now, across the United States, we're maintaining about a 2.8-day turnaround. That's related to the capacity that the labs have, and I think the labs have the same view that we do, that we're going to see a lot more infections over the course of the late fall and into the early winter. And so they're continuing to add capacity. And with regard to, that's the kind of thing big companies like ours are good at. We've got a lot of goods moving in and out of these retail pharmacies on a daily basis. And teams that work on those things have been able to sort of move over and work on these, which has been really gratifying for us to see how quickly we've been able to sort of build up a wholly new service like this.
Thank you.
My next question is, what is your biggest concern in regards to increasing testing capacity over the next several months?
The biggest concern I have is as the flu season really starts to hit, exactly how many outlets are going to be available to take care of people who have upper respiratory tract symptoms. It's a big issue for us, obviously, when you run retail clinics. In the period of time from November through February, you can see 60 to 70% of your being upper respiratory tract infection. And that's the same thing with doctor offices and emergency departments and urgent care. I just don't know how many are going to be available to treat people who are symptomatic, with the concern being that someone could be actively infected with SARS-CoV-2 and create risks for other people in waiting rooms and things like that. That's why we've been designing for the last 6 months this sort of approach where we do this sort of 2-part testing and use of kiosks that are designated for use for testing. It allows us to sort of set up a situation where we can test everybody we want to, but we don't have a lot of sick people coming in directly into the retail pharmacy until after we've tested them for SARS-CoV-2. So what we're seeing around the country is that a lot of large hospital systems and things like that opened up urgent care. A lot of those closed down when there was a large close down of healthcare facilities during the initial phase of the COVID epidemic. And those are not reopening. So I'm a little bit worried about capacity. I'm not worried about our capacity because I think, we'll be ready, but I'm a little worried about sort of the capacity around the entire country for testing as we get into the winter.
Okay, thank you.
The next question that I had was, how can we bridge the gap and ensure testing and equipment reach to disadvantaged communities?
Well, you have to do specific outreach, obviously. And, the good thing about our fleet is that we tend to be well distributed. There are still places that have pharmacy deserts, just like there are grocer deserts and things like that. And so people in certain communities might not have the convenience that they really need in order to be able to get tested. To address that, we're working with a variety of different partners to do community-based testing. The good thing about the point-of-care tests is that as long as we can get government permission, which we usually are able to get, we can take a nurse practitioner in an LVN and 4 machines and set up a place where we can do testing in an empty office, in a gymnasium, in places that are in the community. And we're doing that now at a large number of community sites, and we continue to work with states to identify places that are going to need that kind of testing. And I think that sort of approach is going to have to continue to occur, because it is very clear that the bulk of the morbidity and mortality is falling on minority communities, especially low-income minority communities. And those are the people who don't have access to the testing. So we have to address that unfairness. And I think we and others are attempting to do so.
So my question is also kind of related to the supply. You already mentioned CVS's plan for like the flu, but I know some companies producing the COVID vaccine are saying they might have one like by the end of this year. So I was wondering if there was like a COVID vaccine, how would CVS manage like staying in supply of that, as well as all the COVID testing and then flu vaccines and testing?
Well, it's a good question, and one we worry about, because we're starting to sort of turn in a direction. As we've expanded our testing, we begin to turn in the direction of vaccine distribution. It all falls on the same personnel. So we have to begin to get sort of concerned about exactly sort of what we think the most highest priority things are personnel should be undertaking. And but with regard to the vaccine itself, it'll come from the federal government, and the federal government will then give it to one wholesaler, definitely McKesson, and maybe a couple of other wholesalers. These wholesalers are sort of a hidden part of the overall sort of healthcare environment. But if you look at the top 10 companies in healthcare, 3 of them are wholesalers, and McKesson and Cardinal are 2 of the biggest. They'll probably be the people who are doing the distributing from the federal government. So we're used to dealing with them. So we know how to take, they distribute all of our other medications. And so we know how to work with them in order to keep our supplies stocked. We're beginning to add refrigerators, including industrial grade refrigerators, because as you know, some of these vaccines require refrigeration down to sort of -70. And then we're being very careful in terms of sort of discussions with Operation Warp Speed, because we do have to make sure that we have product. This thing where one has to be most concerned about is that you vaccinate somebody, they're coming back in 2 weeks for their booster. You can't not have the booster at that point. So you've got to have sort of ongoing discussion with both the government and the wholesalers to make sure that the supply is going to be there. Now, the smart thing that the government has done is that they basically paid for vaccine ahead of time. So that has enabled the manufacturers to go ahead and manufacture at risk. So while they're undertaking their clinical trials, they're also busy manufacturing. And there's at least 4 and maybe 5 vaccine manufacturers that will say they'll have between 100 million and 300 million doses by January. If that's the case, then we're going to be able to get serious about vaccinating people over the at the beginning of 2021, which I think would be great. Now, we also have to do a lot of outreach and education because we want people to get this vaccine. We don't want people to think, this is not going to be good for me to get. And there are people who have concerns today. I think once we get past the election, whether the Republicans win or the Democrats win, no matter who controls it, at that point, the politicization of the vaccine process is totally sort of unnecessary, and they'll turn it over to the professionals in the government. And just an article in Stat, which is available about the sort of key 8 people in Operation Warp Speed. And I think, sort of you read through that list and you can be kind of proud as an American that there are this caliber of people who are working in the government and working on behalf of the public health. It's really impressive. So I have a lot of faith in our ability to get this vaccine out and get it distributed.
Troy, there was a question from the audience about influenza. One was, do you expect that the demand for the flu vaccine is going to go up this year or similar to past years? And secondly, what are your projections as to how much flu we're going to have in light of the fact that we're physical distancing and wearing masks, et cetera?
Yeah. So first of all, the first question is easy. It's about double right now. Sort of we're at something like, we've given 6 million flu vaccinations. Last year at this time, we were at like 2.7 or something like that. So people want to get a flu vaccine in this environment. So that's good. To me, that's a very good sort of indicator. But then the second thing I'd say is exactly sort of what the prevalence of flu is going to be. There were early reports that came out of the Southern Hemisphere, but the Southern Hemisphere is a lot of different kinds of places. Some of them are like upper middle class places like New Zealand and Australia, where they shut down all the schools, they shut down all the travel, and there was just no importation of flu from the rest of Southeast Asia as usually occurs. On the other hand, there was also a report, and they didn't have much flu. And there was the same reports came through Latin America, but they were more spotty in Latin America. And you have to wonder exactly sort of how much ability they've had to really monitor their flu situation, given the challenges associated with COVID. Having said that, if you talk to my wife and I were sort of comparing notes on this, neither of us have had a cold since March. We're not seeing a lot of people and being very careful when we do. And it just demonstrates that, a lot of your common cold is going to be through relatively sort of spontaneous contact with people who aren't wearing masks and who are closer to you than 3 feet for an extended period of time. And, if you're being careful today, you're staying 6 feet away from people or you're wearing a mask. And as a result, that should reduce the vector for the flu. So really unclear, but good to take flu off of the possibility of things if you do get sick. So that's all the more important to get your flu shot right now.
Mm-hmm. Pass it back to the students.
So the question that I had was, what are your thoughts on how specific COVID resources and that vaccination can be distributed by CVS?
Well, as I said, I think that I think not only CVS, I think the independent pharmacists, the other large chains, they're all going to play a role. But unlike 10 years ago, the pharmacies are much more oriented towards provision of care, especially around things like vaccines and the like. And I think that, had this pandemic occurred a decade ago or a decade and a half ago, you probably wouldn't have had the retail pharmacies involved at all. Now, I'd say the retail pharmacies are going to play a leading role in terms of being able to provide basically depots of distribution. The good thing that you get from the 70 or 80,000 pharmacies you have in this country is that they're widely distributed, and nobody's more than 2 or 3 miles away from their local pharmacy. And so, most of us have put in place digital capabilities to allow scheduling, and that's going to increase the ability of our pharmacists to be able to give really relatively sort of large numbers of vaccinations. So as I said, our team thinks 25 to 30 million out of our 10,000 pharmacies is doable on a monthly basis. And Walgreens has 10,000 in their chain. Walmart has 6,000. Large grocers like Kroger's, people like that, bring in 3,000 to 4,000. You can see that you've got the capability for distributing. Now, we are, as you asked before, we are going to have to work on how we're going to distribute those vaccines in places where there aren't as many pharmacies available. But fortunately, there's a number of sort of national the assets that will be willing to sort of work with us in terms of setting up vaccination sites. I don't know about Jim, but I remember back when I was a kid, basically sort of getting a polio vaccine. It was given out one summer evening in a parking lot of a church that we all went to. So you'll see some of that, but I think what we have to do is get those communities mobilized as well to understand that this vaccine is going to be something that's important for everyone and good for the community, good for you as a person, also good for all the people who are in your community.
So many companies had to make difficult decisions due to limits in medical technology and supplies during the beginning of the pandemic. So I was wondering, what are some things you learned during the pandemic, and how you would use that to guide the company in the future? And also, as a follow-up question for the future, if the United States has more difficulties maintaining the production of the COVID vaccine, if there's any way CVS would help aid the production.
Well, we're not going to be in the production. The companies are going to get paid reasonably. They're going to get paid sort of the fees that they'd expect for the vaccine. And so, in this particular circumstance, capitalism is going to work, because they realize that there's a reasonable profit to be made there. And so, they've gone into this in a sort of an unhesitating fashion. If you look back in January and February, there were a couple of articles written by people who were saying, who's going to make this vaccine? But that was something that the government addressed right away. And although the government, gets criticized for a lot of different kinds of things, in this particular circumstance with regard to Operation Warp Speed, I'd say, they get an A+ in terms of creating a reasonable sort of economic process so that vaccine manufacturers were willing to jump in. I don't think we need to be focused on election day in terms of sort of when the vaccine should be, but that's a political issue that's obviously beyond sort of my set of capabilities to understand. So the vaccine will be produced. I think what we learned from the pandemic is a lot of things like you all have learned, which is that you can do things differently. And I think, again, sort of 10 to 15 years ago, I don't think this would have been so easy. We just simply did not have the bandwidth, the narrow definition of bandwidth to be able to do the things that we're doing today. Our company, about half the people are office-based, about half the people are out in stores or other places where they're working in the environment. We have a variety of different companies like home infusion companies and pharmacy, people who provide pharmacy services in long-term care facilities, and care management companies where the care managers are at home, out in people's homes. So half of our people are out there working, and they have had to sort of work and use appropriate precautions. And like everybody else, we had trouble obtaining the necessary protective equipment that we needed in the March-April timeframe. And we've been working very hard to warehouse enough to get us through till next July. I'd say we're about 2/3 of the way there right now. But fortunately, we began to lose some stores, especially in New York, New Jersey area, but we never had a substantial shutdown in our chain. We always kept people at work, and I think today people are at work, they feel good. The more and more of our customers are wearing masks that they do, and we're not seeing an inordinate amount of infections sort of coming out of our stores. With regard to the office workers, everybody went home. I was telling Jim, I was traveling yesterday with our senior executive team, but that's only the first business travel I've done since March, whereas I was probably 2 days a week on the road. You found out that there's a lot of things you can do on a virtual basis and not lose that much. And I look at two things recently. One is I'm in charge of sort of quality for our overall organization, and I have a lot of sort of record keeping about that, and it's sort of a nice dashboard that I can look at. I put that together for the board. We have a board meeting next week, and striking improvements in overall satisfaction of our customers sort of across the board. People are happy with our mail order facility, they're happy with our retail pharmacy, they're happy with our front end, really palpable increases, statistically significant increases. And then that, we just finished our engagement survey. And a company like ours, engagement survey is a big deal. You ask people how they feel about their workplace, and we typically get 90% of those returned. Back when I worked in the hospital, we were lucky to get sort of 30%, but in a big company like ours, we sort of insist on it, and our engagement scores are way up. People are satisfied with their work. They feel like they're doing important work, and they feel like we're a company as a whole is sort of moving forward. So, both engagement and satisfaction of the customers being up, I've got to feel pretty good about the way things are. You have to wonder, it's hard. We're going to be in this thing for a year and a half. And I think that was the hardest thing for people to understand. I remember when it first happened, if you know anything about sort of virology or viral epidemiology, there were papers available, and there was going to be a stuttering course of this thing with broad infection and a very reasonable amount of morbidity and mortality over the course of a year and a half, 2 year period of time, whenever there was going to be a vaccine available. So my initial calculation was somewhere between 600,000 and 900,000.
Waiting for Troy to come back.
Over a 2 year period of time, and that's just simply a matter of sort of how effective the virus was, and our own disposition towards being able to sort of do appropriate social distancing, as well as the morbidity associated with the virus. So you could sort of see the writing on the wall a long time ago, and people just couldn't get their hands around that. But what I'm trying to make is that now we're halfway through it. I think more and more people are sort of thinking, I'm not going to get back in the office until next summer. And, the rest of the school year, you're going to be having the same thing that you're going through sort of right now. People are sort of getting used to that. But the big question is going to be, how much long-term change is there? Does this end up seeming like, sort of we're 2 to 3 years out, and it's like a summer storm that passed and everybody's back in the office? I'm not so sure about that. A big company like ours, where we had 150,000 offices or cubes, I think we're thinking we could downsize substantially. So when you think about that, you wonder how many other changes there are going to be in the country overall. And then the other thing I'd say is that I can be a bit of a pessimist about this, but it's going to be a tough winter. There's no doubt about it. It's going to be a pummeling, because you're not going to be able to be outside. You're going to have less opportunity for sort of social interaction. There's going to be a lot more illness around. We're going to get nervous about hospital beds availability and things like that. So I think we've already got sort of an epidemic of depression, and I think that's going to get worse. So all those things sort of account for both approaches you have to take from an HR point of view at big businesses like ours, and also thinking about sort of how you get this vaccine distributed so people can begin to get a sense of living a sort of normal life again. What that normal life will look like, I don't know. I read the other day in the paper, and it seemed to me like it was true that people have gotten so much experience with remote learning that snow days are a thing of the past. So there will be some changes, some substantial changes, I think.
Troy, there was a question from the audience about what would the price range be for the vaccine?
If you go to a CVS today, you'll see signs that say free vaccines. It took us about 6 years to get the lawyers to say it's free vaccines. But what that means is that the vaccine, both the vaccine administration fee and the cost of the vaccine are almost universally covered by insurance. And the other thing is that, you know, sort of insurance is available to almost all Americans as a result of the ACA. There's still a reasonable number of people who are uninsured, but at least with regard to testing, that's been handled relatively easily by having us have a facility that we can charge. It's actually run by United, one of the other insurance companies, where we send people who certify they don't have any insurance, we send the claim to United and the government pays for it. So I think the same thing will happen with the vaccine. People will, it looks to me, you know, this is not entirely clear, but it looks to me like the insurance companies are going to pay for the vaccine, and those people who don't have insurance, the government will pay for. But I'm not thinking that anybody, any place that's distributing vaccines is going to be turned away because they don't have insurance. The cost associated with it, there's a lot of discussion about that. You know, it looks to me like the numbers are coming down between 20 and 35 bucks for the vaccine. I think that's a single dose, so maybe double that for those that are requiring sort of 2 doses, which is not out of line with what we would pay for other broadly distributed vaccines. And then an administration fee that tends to be something in the order of sort of 15 to 20 bucks or something like that. So, you know, if you're running an insurance company like we do, you're looking at the cost of test and you're looking at the vaccine, but you're also understanding that you've got a lot less claims coming through because people are not using the emergency department, they're not using urgent care, they're not going in the hospital as much. Our hospitalization rates are still depressed compared to last year, even at this point. I think everybody's going to be able to, I think everybody in the entire system's going to be able to sort of handle the costs associated with this.
Good. Well, let's go to the final section here on private and public health response. Morgan, do you want to get started? Last set of questions.
How do private and public health sectors differ in their approaches to handling COVID-19?
How do they what? What was the verb there?
Differ.
Differ. Oh, differ. Yeah. I have not looked closely enough at those places that would be considered mostly sort of public health run or public healthcare systems like Britain or something like that in terms of what their plans are for distribution. But I would say that the differences in most of healthcare have blurred quite a bit. There will be, you know, the states have always played an important role, especially with regard to childhood vaccines. And there's an entire process and apparatus for childhood vaccines run through the state health departments. But the state health departments don't tend to sort of speak to one another very well. So the government is planning to put into place an overarching information system. So I know Morgan came into CVS 10 days ago and got her first vaccine. She needs to come in for her second dose. And she got the Moderna mRNA vaccine, and that's when we have to get the sort of second dose of. So we need that kind of information. But the private sector is very good about the distributions that I suggested, and then sort of appropriate reporting. You know, all of our stuff we can land in our electronic medical record. We have an Epic electronic medical record that goes across our entire enterprise. So the record keeping is very good. So my view is that you know, the differences between sort of a public approach and a private approach are beginning to blur. I also have a sense that everybody's going to be relying on everybody else to get this vaccine out. So there's not going to be some sense that these are my people to vaccinate and you sort of stay away from them. We're going to be happy to have the community health centers do as much vaccination as possible, but we're also going to be prepared to go out and vaccinate at a YMCA or something like that if a local government wants us to do that.
Thank you.
So with children returning to school, they have a much higher risk of both spreading and getting the virus. So I was wondering if CVS has done anything to help in preventing the spread with children, and if you have any recommendations for other companies.
No, right now, I mean, yes and no. The interesting thing has happened is that Abbott came out with a test called a Binax test. It's an old test. This is mid-1980s technology, and they sort of remodeled it, and they brought out a test that cost $5 for testing. Now, the problem was that I think that they thought that maybe they could do this testing and basically have people sort of walk up like to a pharmacy counter and get a test. But the testing does require trained personnel, and it requires what we call CLIA waiver, which means we have to get sort of a certificate from the FDA in order to be able to do the testing. And then the testing requires a certain amount of professional time, which adds on costs sort of associated with it. The government bought all the Binax tests that were available, 150 million of them, $5 a pop, $750 million they paid Abbott. They brought all of them in. They're basically, Abbott is taking this entire supply, and that's for the federal government. Now the federal government's working with the states, and they're going to ship all those to the states. And they want to use them in two places. One, they want to use them in long-term care facilities, and secondly, they want to do it with kids. But the question is, which kids should you be testing? You know, like you all, or I consider you sort of private citizens and associated with Albion College, and you're getting tested, whether or not you're symptomatic or not, and you're getting a PCR test. But I don't think that the same thing sort of applies to you know, K through 12 public schools. So we're waiting to see how the states think they might use these tests, because basically they're going to go to the states for free, and then the states are going to have to sub it to. I can tell you, in talking to a couple of states, what they think they want to do is basically, if a kid shows up symptomatic, they want to send them to us, have us do the Binax test, and then get the results. Now, that's based on symptoms. That after the Binax test, since it has we're going to have a reasonably high false negative rate, they want them to get a PCR test as well. So at our place, we'll also swab them, send that swab off for a PCR test. The reason why they do it, because they don't want to do 2 tests on every 3 days to get back and start doing contact tracing at that school. So they're using it as sort of an early warning system to be able to find out if people have been infected, and then undertake the contact tracing as quickly as possible. I think that's sensible. From a public health point of view, that's sensible. And so, you know, we're planning to talk to states about sort of how we can get involved with them on this, because we can do the PCR testing ourselves, and right after the Binax testing is done. So that's the way at least one state is thinking about it. We'll see what the other states have to say. But you know, keeping these kids in school is going to be tough, and there's a lot of kids who don't have, you know, sort of sufficient access to a virtual approach for school. You know, there's a lot of overwhelmed parents. So, you know, you do want to try and get these kids back in school if you can do it safely. But as you said, they do get the disease and they spread the disease, and some of them can get quite sick. So, you know, what we're up against is kids going back to school, going into the fall, rising rates of infection. We'll see what happens.
Thank you.
Are there any major concerns with people unwilling to receive testing or a future vaccination? And how can we address these concerns?
Well, I think most of that concern there focuses on the vaccination. You know, you've got 40 to 50% of people saying they're not going to get vaccinated now. We need, in order to get a reasonable sort of herd immunity, you probably need something that's like an 80% efficacious vaccine and 80% of people vaccinated. That will protect everybody then, because there'll be insufficient ability of the vector to sort of move about. You know, sort of having said that, how do you manage that? I think what you have to do is educate people. And there's so much Sturm und Drang about associated with the election right now that it's going to be basically impossible, I think, to educate people between now and November 3rd. After November 3rd, everybody should settle down because, well, after November 10th, whenever the election is decided, everybody should settle down, and calm sort of public health minds will be in control, and we have to set up a very strong sort of campaign. And I think, like a lot of other things, it has to be a campaign that's based on social media. It has to be a campaign that's based on you know, people who everyone can respect. So, you know, the way I think about that, you know, sort of, I need to be seeing an ad on the social media sites that I'm on where LeBron James is telling people, you know, like, we all need to go out and get a vaccine. I got one. You know, though, but we can design those things, and those kinds of things can work. And there's going to be money to spend. There is so much money to spend simply because the pandemic, in terms of the shutdown, is costing what? $1 trillion every 2 months. So you can spend $10 billion and have it be very cost effective in terms of getting the country back to what it feels like is something normal.
So it's important that people with the virus stay home even if they are asymptomatic and don't feel sick. However, we know that it can be hard to convince people of this necessity. And you kind of already touched on this in the previous question, but in what ways do you see medical and public health education changing in the near future to continue to reach people and maintain safety for those around them?
I mean, it's such a simple thing, right? I mean, it's very easy for people to understand that if they are infected, they're going to go out and infect other people. And to some extent, what we need to do is have the country be more oriented towards the fact that there's individual responsibility towards one another. You're not wearing a mask necessarily to sort of block, sort of virus that might come your way. You're wearing it to protect other people around you. So if you sneeze or cough and you happen to be an asymptomatic carrier, it doesn't go anywhere. So, but in some ways the country feels like so self-centered right now that I think some of those messages are getting lost. I hope that's partially sort of the election cycle, and we'll get past that. With regard to what happens after the pandemic and public health, what I hope is that people realize you have to invest in public health. I was stunned when we started doing testing in a couple of states. We were trying to get things set up good with the states. And so I wanted we were going to get positive results right there because we were running point of care tests. And I wanted to get contact tracing initiated immediately because that's the best way to sort of do it. I mean, I guess I was thinking like I was in South Korea or something, because the people in the public health department didn't really even know what contact tracing was. It was actually shocking. And part of it is just because they're overwhelmed with what they had to do on a day-to-day basis. And part of it is just that if you look at our funding for public health, it has been devastated over the course of the last decade and a half. I constantly make the point in my work that we spend way too much money on acute care and not nearly enough on public health. And I'm hoping that, we review where we were with this pandemic, and we realize that we have to treat ourselves as members of a community. And in order to do that, you need a reasonable sort of public health response, because another pandemic is going to occur. I don't think it's going to be another 100 years. It's not something that sort of strikes every 2019. It's going to be back sooner. I think the other thing, though, the point I make that is somewhat optimistic is that, it also begins to alert people to sort of larger issues about health and the planet itself. And, if we have this crisis on us, but we have a boiling crisis with regard to global warming, which is a real public health issue. And I'm hoping that this kind of thing will slowly but surely sort of alert people to the need to consider public health interventions and to consider sort of what's good for other people around us and to consider what's good for future generations.
Troy, we had some speakers who actually were on the front line, both ICU nurses and medical directors of major hospitals in New York when it became a crisis locally in the hospital. But you're a big company, and when it became obvious to you and your colleagues while you were reading these reports, was there a playbook that you had, the crisis management for a pandemic that you pulled out, you followed it? What kind of sort of corporate preparation did you have for a crisis like this, or was it just so different than anything?
No, we had nothing on the shelf. Now, sort of the good thing about our place is we got a reasonable number of sort of well-informed people. When I came to CVS 12 years ago, there were two other doctors, and the day I arrived, one resigned. So that was it. Now I probably got about 800 doctors, and I got 2,000 people sort of doing analytics. And so now they're not oriented towards public health. They're not we don't really have an occupational health department, But I think we had a lot of capability in terms of things we could do from a logistics and operations point of view. We have great operators. And we were able to come up with ideas about sort of things that we could be doing and then make them up out of whole cloth. The good thing about the organization was it realized that it had a role to play in helping deal with the pandemic, and we sort of jumped into it. But I can tell you that there's a reasonable amount of things that a number of us are sort of writing down now, so there's going to be a little bit more of a playbook next time around.
But I think last question, I'm going to pass it to Becca about career and preparation for your career.
So I was just wondering, how has your career and past experiences in the medical field prepared you for your role at CVS, specifically during COVID-19?
You know, I'm hitting it, you know, sort of, Jim didn't tell you how long ago we met, but, you know, I'm sort of hitting this at the end of my career, and, you know, I've got sort of a reasonable amount of authority sort of stored up over the course of having worked here for 10 or 12 years. So it allows me to sort of say, I think we got to go this way, or I think we got to go that way. And people are generally going to adhere to that. So the good thing about getting, you know, there's a lot of really bad things about getting old, but one of the good things about getting old is, you know, people feel like you've been around enough to know and that you're going to be sort of wise enough to sort of help them. So I'd say, you know, sort of over a 35 or 40-year career, you know, I keep up, you know, some of you, all of you are studying some sort of biology or kinesiology or biochemistry. You know, I keep up and always have kept up with basic science. And in a role like mine, you've got to do that. That people have got to be able to turn to you for sort of that expertise. But then also you got to have impulses about sort of what the right thing to do is. And I think, you know, my career has basically sort of prepared me for that. So it's gratifying to be able to have the company play a role like this in the pandemic.
Great. I think we've come to the end of the hour. I want to thank the students for spending your evening with us and sharing your time with Troy, in particular Troy as well, telling the story of how this played out. You know, I can't imagine how things were like in March, because essentially most of your people were essential personnel.
Yeah.
And I'm sure you're going to think back, maybe think back, you wish you had retired before, but I know we had the conversation. I think this was your moment. And I think CVS benefited from the fact that you were there with your experience. So thanks for what you do, and thanks for being here tonight as well.
Thank you for having me. Yep.
Take care. All right.